I'm Dr. Jeff Donovan. I want to thank you for taking the time to join me as we review the top 20 studies of 2021. It's hard to believe that a full year has passed since we last reviewed the top 20 studies of 2020, but here we are again at the end of 2021, looking back at the top 20 studies of this past year. We'll begin with a very interesting study from China, looking at the role of exercise in actually improving density in patients with androgenetic hair loss. Very interesting study. Study 2 looks at Setipiprant. Setipiprant is a drug which blocks the prostaglandin D2 receptor. Data over 10 years ago started asking the question as to whether a drug like Setipiprant could actually be used to treat androgenetic hair loss. I'll review this long-awaited data. Does Setipiprant help androgenetic hair loss? From there, we'll look at oral minoxidil and the use of 5 milligrams of oral minoxidil in treating androgenetic hair loss in males. Is it helpful? What are the side effects? From there, we'll look at the use of finasteride and dutasteride in treating androgenetic hair loss in men over the age of 50. There's been a long-held view that perhaps these drugs are less effective in older males. Is this actually the case? This important study really contributes to the literature by answering that question. From there, we'll move on to 3 interesting topical anti-androgens: topical cetirizine, topical spironolactone, and topical finasteride. You might recognize cetirizine as an antihistamine that goes by names like Zyrtec, Reactin. Can the topical agent actually be helpful in androgenetic hair loss? What about topical spironolactone? Oral spironolactone has been available for about 35 years to treat female pattern hair loss. Does the topical agent actually help? Study 8 looks at topical finasteride. Very important study by Dr. Piraccini and colleagues, a double-blind, placebo-controlled trial, largest of its kind, over 300 patients. Does topical finasteride help? And how does it compare to oral finasteride? From androgenetic hair loss, we'll move to alopecia areata, a common autoimmune disease in the population. The first study we'll review from Dr. Gutman-Yaski and colleagues in New York tells us that there's perhaps more systemic inflammation and inflammatory tone and perhaps cardiovascular risk in patients with alopecia areata than we've really appreciated before. Really important study which puts alopecia areata on the map as really a systemic disease. And there's this emerging trend over the last 5 to 6 years that moderate to severe alopecia areata truly is a systemic disease. There, we'll move on to late onset alopecia areata. Most alopecia areata, as you might know, occurs in individuals under the age of 40, but some patients develop their very first episode of alopecia areata after the age of 50. We call this late onset alopecia areata. What are the characteristics of this group? Study 10 is a study of minoxidil, not in humans, but in dogs and cats. I'll introduce you to the largest study of its kind, addressing the toxicity of minoxidil in dogs and cats. An incredibly important study for all of us to know about the toxicity of minoxidil in dogs and cats. And even a drop can be very harmful to our pets. From there, we'll move on to scarring alopecia. Scarring alopecia is this group of hair loss conditions that leads to potentially permanent hair loss. We'll begin with central centrifugal cicatricial alopecia, or CCCA. CCCA. CCCA is a common condition in Black women. 15% of Black women have CCCA. The first study by Dr. Samrio and Mir Marani from San Francisco really questioned the prior evidence about the relationship between fibroids, uterine fibroids, and diabetes in women with CCCA. From there, we'll look at an important study addressing the potential association between CCCA and breast cancer. The first of its kind in that topic, and a really important study to know about. From CCCA, we move to frontal fibrosing alopecia. FFA is an epidemic. Increasing rates of FFA are being reported around the world in women and in men. We'll look at the potential association between a condition called lichen sclerosus. What is lichen sclerosus? And are the rates of lichen sclerosus truly increased in FFA? From FFA, we move to LPP, lichen planopilaris. The first study by Dr. Connick and colleagues from the Cleveland Clinic asks the question, are patients with LPP at increased risk for cardiovascular disease? Prior studies have suggested maybe not. This study suggests maybe they are. An important study for us to know, and I think it's a paradigm shift in how we understand this condition. From there, we'll look at a study by Dr. Sergio Vano-Galvan looking at the role of oral minoxidil in treating LPP, at least improving hair thickness in patients with LPP. Does it help? Study 17 looks at breast implant illness. Breast implant illness is a subject matter that has not received a great deal of attention, but breast implant illness is a condition whereby patients who have received breast implants report an array of symptoms. Some patients appear in clinic asking if their hair loss is related to breast implants, and more importantly, should they have the breast implants removed. This study from Utah addresses the subject of breast implant illness and helps us somewhat address this question. What is breast implant illness? Should patients have breast implants removed? It's a challenging subject, but a really important one for us to all know about as we counsel our patients to the best of our ability. Study 18 and 19 address chemotherapy-induced alopecia. A large proportion of patients receiving chemotherapy develop hair loss. Permanent chemotherapy-induced alopecia refers to permanent hair loss or persisting hair loss after patients have chemotherapy. Not all patients actually regrow back their hair fully after chemotherapy is done. This is permanent or persistent chemotherapy-induced alopecia. So what are the characteristics of PCIA? This study 18, looks at some of those issues. Study 19 looks at scalp cooling. Scalp cooling devices have been used in Europe for almost 2 decades. They've only been introduced to the US in 2015, where they were first approved. Does scalp cooling help all patients? We'll look at a study looking at scalp cooling in Black women and asking the question, is scalp cooling effective in Black women undergoing chemotherapy? Really important study for us to know. Finally, study 20 looks at the powerful role of photography in the hair clinic. How does photography impact the anxiety that patients feel? And how does photography impact the desire to continue a treatment plan? So these are the top 20 studies of 2021. I really do thank you for taking the time to join me. I hope these studies are informative and helpful to you in some way. I don't have any conflicts of interest about anything I'm going to review. The disclaimer, of course, is that hair loss is a complex matter. So if you have hair loss, be sure to review your hair loss with a specialist who can help you first with a diagnosis and then a treatment plan. Congratulations to all these 20 authors and research groups. And these are some of the top 20 studies of 2021. So we're going to review 8 very interesting studies of androgenetic hair loss. And androgenetic hair loss is one of the more common types of hair loss. It looks different in women on the left than men on the right. But when you look up close, a very similar phenomenon is happening in androgenetic hair loss. And that is that these thick hairs are becoming thinner. And whether you're male or female with androgenetic hair loss, that's what's happening. There's a complex array of factors that cause genetic hair loss, including genetics, possibly some environmental factors, and the effects and sensitivities of hormones. But it's becoming increasingly clear over the last few years that something called metabolic syndrome is very, very relevant to patients with androgenetic hair loss. And I'd like to review with you what metabolic syndrome is. I think it is one of the most neglected areas of hair loss medicine. And the implications of what I'm about to say are really pretty profound. And I do think we need to pay more attention to it. So metabolic syndrome is a cluster of conditions that increase one's risk of heart disease and strokes. And things like high blood pressure, high blood sugars, high cholesterol, and obesity are the factors that comprise metabolic syndrome. And metabolic syndrome is certainly very common in the population. But we know without any doubt that patients with androgenetic alopecia are at increased risk of metabolic syndrome. And it's something we don't talk a lot about. It's been known for quite some time, and every year more and more studies come out that can, convince us even further, but we really don't need convincing. But patients with androgenetic alopecia, whether male or female, are at increased risk of metabolic syndrome and increased risk of heart disease, increased risk of heart attacks, increased risks of strokes. That's clear. We know that exercise and other factors like diet really can reduce our chances of metabolic syndrome. That's pretty clear. Well, wouldn't it be great if exercise could somehow affect androgenetic alopecia? And so one of the studies I'll review with you today, our first study, looks at the role of exercise in androgenetic alopecia. So Zhong and colleagues, this is a study from China, looked at that very question: does exercise impact androgenetic alopecia? So the authors performed a survey of 592 patients, both men and women, with androgenetic alopecia, looking at what type of exercise do you do, how often do you exercise, how long do you exercise? And the results are pretty profound. The results suggested that after 6 months of observations where physicians followed the patients, about 15% of patients had an improvement in their hair. 75% of patients were not affected by exercise, and 8 or 9% had actually an aggravation or worsening. Exercise helped scalp itching. Exercise helped reduce greasy scalp symptoms, and exercise improved anxiety and depression. And so in this study, which is a somewhat simple study, but yet an elegant study nevertheless, suggests that exercise may have a role in helping androgenetic hair loss. And improvement in hair loss was related to how often you exercise. So if you exercise more, it seems better for the hair. If you exercise longer, it seems better for the hair. But one of the most important factors is aerobic exercise. So an hour of aerobic exercise per day is wonderful for the hair. And patients who were exercising with aerobic exercise had a 5-fold greater chance of having improvements in their hair compared to patients that were just going about their day. Patients that were exercising 60 minutes or more each day had greater improvements in their hair than people that were exercising 30 minutes or less. So this is a pretty interesting study. I think it's becoming pretty clear that we should be talking exercise in our patients with androgenetic hair loss. And certainly aerobic exercise for 60 minutes, provided someone doesn't have a contraindication to exercise, provided it's a good idea for this person to exercise, this may be a very valuable thing to prescribe. We know exercise can decrease the phenomena related to metabolic syndrome, and it seems exercise can impact androgenetic alopecia. Pretty interesting study. From there, we move to a medication called Setipiprant. And there's some attending today who are very familiar with Setipiprant, but if you're not, I'll bring you up to speed. This is some data that we've been waiting for 10 years, and we're ready tonight. So about 10 years ago, some very interesting work by Dr. Garza, Dr. Cotzrelis's group showed that in the bald areas of the scalp, there's more prostaglandin D2 in the scalp, about 3-fold higher in a small number of males that were sampled. So there's more prostaglandin D2 in this area, less in the area where there's hair that's not balding. So let's learn a thing or two about prostaglandins, and then we'll come back to this interesting study. So prostaglandins are proteins. There's many types of prostaglandins. Some prostaglandins promote growth, like prostaglandin F2. Some prostaglandins, like prostaglandin E2, also promote growth. But prostaglandin D2 inhibits growth. And when there's lots of prostaglandin D2 around in the scalp, it inhibits hair growth, and it actually favors hairs to miniaturize. And so Dr. Cotzrelis's group, Dr. Garza's paper, in Science Translational Medicine show that there's higher amounts of prostaglandin D2 in the scalp. Now, wouldn't it be great if the ability was there to block the production of prostaglandin D2 in the scalp? And the answer is that we do have that type of medication, and that is Setipiprant. Setipiprant is a medication that is able to prevent the binding of prostaglandin to the receptor. And we've been waiting quite a while for data showing us whether Setipiprant can be helpful in androgenetic hair loss. In fact, we've been waiting almost 10 years. And this study from October by DuBois and colleagues looked at whether Setipiprant can be helpful for androgenetic alopecia, whether Setipiprant, this prostaglandin D2 blocker, can help androgenetic alopecia. So this was a double-blind, multi-center study, 32 weeks. It's phase 2A clinical trial. It looked at males 18 to 49 years of age, and patients were randomized to either Setipiprant, 100 milligrams twice daily, or placebo twice daily. The study investigators looked at target area hair counts. How much hair is growing in a little target area? What do patients think of their results? They don't know if they're getting placebo. They don't know if they're getting the real Setipiprant drug, but what do patients think? What do investigators think when they look at the scalp? And how safe is this drug? 169 study participants were randomized to these various groups, including Setipiprant, placebo, and finasteride was also included in the early part of the study. Individuals that were receiving placebo didn't have any improvement. And that's not surprising. That's what we would hope for with placebo. No change in target area hair counts. Patients didn't think they were better. Investigators didn't think they were any better. Finasteride led to an improvement in all these domains. Grew more hair. Patients thought they were better, and investigators thought they were better. What about Setipiprant? We were waiting almost a decade. What did the data show? There's no improvement. This is a really well-conducted study and a very nice study. And I think it's a really important study. You know, there's data that prostaglandin D2 is higher in the scalp. There's clear data in when you add prostaglandin D2 to Petri dishes that it stops hairs from growing. But in this study, a prostaglandin D2 blocking medication didn't seem to help androgenetic alopecia. The drug got into the scalp. The investigators were pretty clear that the drug got into the scalp, but it didn't help androgenetic hair loss. Whether Setipiprant could be used topically, we don't know. Whether the results would be different, we don't know. Whether higher doses could be beneficial, we don't know. But this well-conducted study suggested it didn't help. So we move now to oral minoxidil. Oral minoxidil is very popular in androgenetic hair loss, and oral minoxidil has been around a long, long time. In the 1970s, 1980s, minoxidil was used as a pill for treating blood pressure at anywhere from 10 milligrams right on up to 100 milligrams. 30, 40 milligrams were pretty typical doses. And it was discovered that people using oral minoxidil grew more hair, and that led to the first FDA-approved medication for androgenetic hair loss in the late 1980s. And so topical minoxidil has been very popular and very useful. There's been an increasing trend now to use oral minoxidil for treating hair loss at anywhere from 1/4 milligram to 5 milligrams. And so there's been a number of studies in the last several years. Oral minoxidil has been quite popular in various parts of Asia for quite some time, but it's now popular in various parts of North America, Europe. And it's been studied in many different types of hair loss, and we'll focus now on its use in androgenetic hair loss. So this was a very nice study from Thailand looking at the use of oral minoxidil 5 milligram dosing in men with androgenetic hair loss. And so it was a prospective study of 30 men aged 24 to 59 with androgenetic hair loss, Hamilton-Norwood scale 2 to 6. And they used oral minoxidil once daily for 24 weeks. First dose they took at night, every other dose they took in the morning. And the investigators looked at hair counts, how much hair grew on the scalp, did the hair diameter change, did photographs improve in patients using oral minoxidil, and what did patients think of the drug? And so in the study, oral minoxidil had a significant increase in the total number of hairs growing in a given area, as well as an increase in what we call non-vellus hairs. So thick hairs, big hairs, significant hairs. At 24 weeks, there was an increase of total hairs of around 19%, and the non-vellus hairs increased about 23% by week 24. And there was an increase in hair diameter of about 9 micrometers, and that equated to about 15% by week 24. And so when investigators looked at the scalps and they looked at the vertex, they could see that about 43% of patients had a great increase in their density. There was a moderate increase in 50% and a minimal increase in 6.7%. The frontal area responded a little bit less. 10% of patients had a great increase in the frontal area. About 60% had a moderate increase, and a quarter had a minimal increase. But everybody had some degree of improvement on 5 milligrams. And patients felt satisfied that they were getting some degree of improvement. What were the side effects? Well, excessive hair or hypertrichosis happened in 93% of patients. This is a study that is certainly not as big as some of the other studies that have looked at side effects, but these are consistent with other studies. Swelling in the feet or pedal edema occurred in about 10% of patients. Patients who were obese tended to have a higher chance of getting pedal edema. There were no serious cardiovascular effects with this oral minoxidil 5 milligram dose. This is a very nice study because they went on to look at EKG changes. Are there any blood changes? Are there any chest X-ray changes? 6 out of 30 patients had abnormal EKG changes. 2 patients had premature ventricular contractions. There were some T-wave inversions, but these were felt to be not significant. There was no change in electrolytes. There was some increase in liver enzymes, which were very, very mild, but 30% had a mild increase of ALT, which is a liver enzyme. So I think that's interesting because we certainly don't order blood tests very often in patients on these low doses of oral minoxidil. And so this is a very interesting study because it certainly adds to the body of data that suggests that 5 milligrams of oral minoxidil is helpful in males with androgenetic hair loss. And the point that these authors make is that with this data, 5 milligrams of oral minoxidil certainly seems to be as good, if not better, than data with oral finasteride, oral dutasteride, which are used for androgenetic hair loss, and better than topical minoxidil. And so this study is suggesting that 5 milligrams of oral minoxidil for men could be a very helpful option, and certainly more attention and study are needed, but very helpful. From here, we turn to studies of oral finasteride and oral dutasteride. These are medications called 5-alpha reductase inhibitors. Oral finasteride is FDA approved for males with hair loss. Oral dutasteride is not approved for males, but it's used off-label, and it certainly is approved in other countries like South Korea. If you look at the packaging for finasteride, you will see that it is approved for males 18 to 41 years of age. And so technically speaking, if you use finasteride in a 17-year-old who's rapidly balding, you're using it off-label. And if you're using it in someone 45, 55, 75, you're using it off-label. And so the question is, does finasteride really work very well in people 50, 60, 70? Does dutasteride work well in those age groups? It's a pretty good question. Finasteride and dutasteride are medications which block the 5-alpha reductase pathway, so they affect hormones. And hormones are decreasing as we age. Testosterone decreases from 18 to 100. Free testosterone decreases. And so do these hormone blocking drugs really do anything as you get 60, 70, 80, 90? DHT also drops off as we age. And so very reasonable question to ask, do these drugs work in slightly older individuals? Well, this isn't the first study. Dr. Whiting, Dr. Olson performed a very nice study back in 2003, showing us in males 41 to 60, finasteride helps. This study that I'm about to review with you really looked at males 50, 60, 70, and over, and does finasteride and dutasteride help? And this is a study by Kang and colleagues. So this was published in January in the Journal of the American Academy of Dermatology. It was a retrospective review of the efficacy, the benefit, as well as the adverse events of finasteride and dutasteride in men over 50. There were 709 men that were treated with finasteride or dutasteride for more than 6 months that were recruited into this study. And 2 dermatologists looked at photographs to see how much benefit occurred. This is a very common scale that's used in hair loss medicine, and this was used in this study. If a patient had no change after 6 months, they were given a 0 score. If their hair loss worsened greatly, it was -3. And if it improved greatly, it was given a score of +3. So how did patients on dutasteride and finasteride do? Well, this study showed that about 93% of patients improved, and they had good data for about 499 patients. 176 had a +1 score, 228 had a +2 score, and 60 had a +3 score. So about 93% of patients had some kind of improvement. Here's a patient with a +3, very nice response. Some patients had more mild responses, but finasteride and dutasteride benefited men over the age of 50. What about in these upper age groups? And this is something in this study that I found particularly interesting in the supplementary data that was presented. And that is that in men 65 to 70, 70 and above, finasteride and dutasteride still had a benefit. And I think that we have been of the opinion that finasteride and dutasteride are helpful in men 20, 30, 40, 50, 60. And some of us have been of the opinion that in men 60, 70, and 80, there's absolutely no use to use these drugs. This study suggests that it may still have benefit. And so I think that's a very helpful point. As many on tonight's webinar are aware, one of the concerns about finasteride and dutasteride are the side effects, including sexual dysfunction. This study showed that sexual dysfunction occurred in about 2% of males over 50. And this was very similar to data that's been collected for the last 25 years in males under 50. So suggesting that side effect profile is pretty good as well in males. So the conclusion here is that these medications are certainly on the list in men over 50 to consider. We move from oral medications to topical medications, and topical medications are a very important subject. There's been a huge trend in the world to using more and more topical medications to treat hair loss because of the greater safety margin that these drugs offer. And so we're going to look at some very interesting studies of topical cetirizine, topical spironolactone, and topical finasteride. We're going to begin with studies of topical cetirizine. Now, cetirizine you may know as Reactin, Zyrtec. There's generics as well. This is cetirizine. It's an allergy medication that's very well known. So why are we talking about it for hair loss? Well, we come back to this slide about prostaglandins. We can't get away from prostaglandins. They're very important in the scalp. Again, some prostaglandins improve hair growth, some inhibit hair growth. Cetirizine promotes increases in prostaglandin E2, which may promote growth. and cetirizine blocks prostaglandin D2, which is an inhibiting prostaglandin. And so this is the reason we're talking about cetirizine. Studies of cetirizine have been around for a couple of years now. Dr. Rossi and colleagues in 2018 performed a study of about 85 patients looking at the role of cetirizine in androgenetic hair loss. And Dr. Rossi showed that cetirizine may help at 1% topical concentration in the treatment of androgenetic hair loss. This was a study with some patients receiving cetirizine and about 18 patients receiving a control. Caro et al. Was a study again by Dr. Rossi's group looking at topical cetirizine 0.5% in one patient who was receiving a chemotherapy cancer drug, and showed that they had an improvement. So some data out there suggesting that topical cetirizine may promote hair growth. I'd like to review these studies by Zaky and colleagues and Mostafa and colleagues. Some very interesting studies which suggest that maybe we should pay some attention to topical cetirizine. The first was a study of topical cetirizine in androgenetic hair loss at 1%. And so this was a study of 60 patients aged 22 to 55, and they were randomized into two groups. The first group received 1% topical cetirizine once a day. The second group received placebo once a day, and there was 30 patients in each group. The study endpoints, the investigators looked at how well does it promote hair growth, what do dermatologists think about the improvement who were involved in this study, and what do patients think about their improvements. Well, when we look at 1% cetirizine, what do study doctors think? Well, 33% of patients were thought to have moderate improvement, and 6.7% were felt to have good improvement. So 2 of these 30 patients were felt to have, that's pretty good improvement. What do patients think? Well, if we look first at the placebo group, you can see that most patients had either no improvement at all, or they had a worsening of their hair. In contrast, in patients using 1% cetirizine, 23% had mild improvement, 16% had moderate, and 3% had good improvement. And so the study authors in this study didn't attach statistical analysis to this data, but the trend here is suggesting that 1% topical cetirizine certainly seems to be better than placebo in improving hair growth in males with androgenetic hair loss. And so an initial useful study that tells us that this is worth studying. And around the same time, this study by Mostafa and colleagues came out in a different journal, looking at 5% minoxidil compared to 1% cetirizine. Again, 1 ml was used twice daily with the minoxidil, and 1 ml was used twice daily with the 1% cetirizine. So this was a study of 40 males, age 18 to 49, and they were randomized to receive either minoxidil or cetirizine twice daily for a period of 16 weeks. And then they had 8 weeks where they didn't have any treatment. So pretty short follow-up time, 16 weeks, 4 months. They looked at how well hair grows, changes in hair density, changes in the terminal to vellus hair ratios. And then they looked at what physicians think about the hair, what do patients think about their hair, and how safe is this medication. And so let me just summarize some of the data by saying that both cetirizine and minoxidil increased total hair density, but minoxidil did it better. There was an increase in vellus hair density with both, but this was better with minoxidil. There was an increase in terminal hair density, but it was not significant at week 16 in minoxidil or cetirizine users. There was no change in hair diameters and no change in the percent anagen phase. And so not the typical robust regrowth with minoxidil that we would expect, but nevertheless, a suggestion that minoxidil is slightly better and both do something. When physicians looked at the data, In the cetirizine group, they felt that about 33% of patients using cetirizine had an improvement compared to about 25% using minoxidil. When patients were asked, what do you think about your hair? 31% of patients using cetirizine felt they had more fullness, and this compared to 58% using minoxidil. So minoxidil 5% twice daily seemed to be better than cetirizine 1% twice daily, but cetirizine still may be an option for androgenetic hair loss. And so in my mind, this is an interesting study because it points to a role for this particular class of medications. This study showed that these drugs were well tolerated. Topical cetirizine was quite well tolerated in this study. And so the question in my mind is not, how much worse is cetirizine than minoxidil, but rather, are there options for us to compound cetirizine in some way with minoxidil to enhance the effect of minoxidil, as both seem to be growth promoting? So from topical cetirizine, we turn to topical spironolactone. And topical spironolactone is something that's been studied for quite some time. But this study sort of revives the potential use of topical spironolactone, and it's a nice study that I'd like to introduce you to. Spironolactone is an anti-androgen that is used for treating female androgenetic hair loss. It is a tablet. It decreases testosterone production by the ovaries and the adrenal glands. It blocks androgen receptors, and it's been around for about 35 years. There's been 3 good studies published in the medical literature looking at oral spironolactone for women with androgenetic hair loss. Famini and colleagues was a study of 20 patients, one of the smaller of these 3 studies, but suggested about 31% of patients benefit. Sinclair's study in 2005 was one of the first, suggested about 44% of patients get an improvement with oral spironolactone. And last year, Burns and colleagues published a study of 79 patients, suggesting that most patients get some kind of benefit. And so the question then becomes, is there any utility of using spironolactone topically? Can we introduce it to the scalp topically? There's been some question about whether this is even worth doing. The thought has been that, perhaps oral spironolactone, by virtue of its ability to stop the adrenals from making as high of androgen production, and the ability to stop the ovaries from making as high of levels of androgens, perhaps this is really the key. And by putting it on the scalp, maybe we just don't get any benefit. But this study set out to again investigate topical 1% spironolactone. It's not the first of its kind. When you dig back in the literature, in 1997, you see an abstract in the Journal of the European Academy of Dermatology and Venereology looking at topical spironolactone. And this abstract suggested that maybe topical spironolactone helps up to 60% of patients with androgenetic hair loss. But it really hasn't received a great amount of attention over the last 25 years. This study by Abdel-Raouf and colleagues was published in January of 2021, and it looked at 1% spironolactone gel compared to 5% minoxidil gel, and also looked at 1% spironolactone combined with 5% minoxidil. How well do each of these stack up? So this was a study of 60 patients, and they were divided into those 3 groups. Patients range from 18 to 45 years of age. There was both male and females in this study, 39 males, 21 females. This is really an important point. We don't use oral spironolactone in men with androgenetic hair loss typically because it increases breast tissue in males. That's called gynecomastia. And so the participants used these topical gels twice a day. Those participants that were using topical minoxidil 5% gel 22% had excellent results. 56% had either excellent or good. So these are pretty decent results. Those using 1% spironolactone gel, similar numbers, 31% had excellent responses. 56% again had good or excellent ratings. But when you combined them, you increased both of these a bit. 40% of people using the combo product had excellent responses, and 90% using the combo product had either excellent or good responses. So a really interesting study. About 20% of patients had side effects using the gel, mainly itching and burning. So that will certainly be relevant as we go about thinking about using topical spironolactone. We'll need to find formulations that don't cause itching and burning in 20% of patients. The topical products cause no headaches, no dizziness. These are sometimes side effects of oral spironolactone, but the topical did not cause this. No enlargement of breast tissue, no menstrual irregularities, no changes in libido or sexual performance, which is a concern about oral anti-androgens. And there was no increased hair growth on the face. One side effect which wasn't mentioned is smell. For those who are on our webinar tonight that are familiar with topical spironolactone, sometimes it has an odor, and this wasn't mentioned in the study. Perhaps this product didn't have odor, but it's certainly something to consider when you're making topical spironolactone. So the conclusion of this study is that topical spironolactone is very much on the list of options as a topical anti-androgen, and it certainly warrants more study. But it certainly is a bona fide topical anti-androgen to be considering. I'd like to speak now about a final topical anti-androgen, and then we'll move on to another group of studies altogether. But the final study in this group is a study of topical finasteride. Finasteride, as we've mentioned before, is an oral medication which is FDA approved for males, was approved 25 years ago. And it's approved at 1 milligrams. Because of potential side effects, sexual side effects, mood side effects, depression, there certainly has been a trend to see if this product can be used topically. And this has started way back in 1997, right when the product first came out. People started thinking, maybe we can use this topically. So there's been 25 years of studies looking at topical anti-androgens, topical finasteride. These studies have been small, 20 patients, 30 patients, 50 patients. Some have been very good, randomized controlled trials, RCTs. But the study I'd like to review with you today by Piraccini and colleagues is a large study of topical finasteride 0.25%. Published this year. I think it's important for us to know because I think this study really shows us that topical finasteride is very much a part of our treatment toolbox, and there's no doubt about that. So this was a study of topical finasteride in males. Many patients ask me, do we use finasteride in females? Well, we do off-label. Finasteride can harm women who are planning to become pregnant. And so the counseling that's needed in using finasteride in females is very, very different. Finasteride is sometimes not used in women at all by some practitioners. Sometimes it's reserved for postmenopausal women, but it can harm a baby. It can harm a fetus. So it's very understandable that many of these studies focus on males because that is where it is formally FDA approved in the treatment of male hair loss. So this was a randomized placebo-controlled trial, 24 weeks, with a large number of centers that were participating in this trial throughout Europe. Males 18 to 40 years of age with mild to moderate hair loss in the vertex or the crown were enrolled in this particular study. 458 participants were enrolled and 323 ultimately completed this study. Depending on the amount of hair loss, investigators would advise the patient how much of the topical finasteride to use. So either 1 to 4 sprays, and it was just once daily. And they used either 50 microliters if they used 1 spray and 200 microliters if they used 4 sprays. And 1 spray is 50 microliters, and that's 0.114 milligrams of finasteride touching down on the scalp. So these 458 patients were randomized to these various groups that you see here. Topical finasteride and oral placebo was group 1. Topical placebo and oral placebo was group 2, both placebo. And group 3 was topical placebo and oral finasteride. So this is the oral tablet form. And this is a very important comparison group as well, because we want to figure out, does this topical finasteride work as good as the oral finasteride? And is it safer? That's really the key here. So 189 patients in the first group, 184 in the second, and 85 in the oral finasteride 1 milligram group. The endpoints that the investigators looked at are the typical endpoints. What are the total area hair counts at week 12 and 24? How much hair is growing in these little areas? What do patients think about this treatment? What do investigators think about the results? And how safe is this? Well, topical finasteride was better than placebo at week 24. So there was an increase in 20.2 versus 6.7 hairs. And so this is really important because it reminds us that clinical trials with placebo often get improvement in hair. Clinical trials with placebo often have patients feeling that their hair is better. So placebo studies are very, very valuable in the hair world. Of course, essential for most of the studies. Investigators felt that topical finasteride was better than placebo. Patients felt that topical finasteride was better than placebo. And one of the more important points in this study is that topical finasteride produced hair counts that were similar to oral finasteride. So the two were very, very comparable. The side effects of topical finasteride were similar to placebo, and I'll show you that in just a minute. And side effects were lower with this particular 0.25% formulation compared to the oral finasteride. And so if we look first at the loss or reduction in libido, it occurred in 0.6% of those using topical finasteride, 2.8% in those using the placebos, and 4.8% in those using oral finasteride. And so the reduction in libido being statistically much, much less in topical finasteride users compared to oral finasteride, and similar to the placebo. How many people stopped the drug altogether because of side effects? Well, there was none in the topical finasteride group. 1.1% stopped in the topical placebo group, and 2.4 stopped in the oral finasteride group. And so this was much lower in the topical finasteride group. And so topical finasteride appears to be similar effectiveness in hair counts as oral finasteride and safer. The investigators in this study, Piraccini's group, found that topical finasteride led to finasteride entering the blood at about 100 times lower amounts, concentrations, compared with the oral finasteride. So much, much less gets into the blood. What is interesting is that serum DHT, or dihydrotestosterone levels, still decreased with topical finasteride. It decreased 34% with topical finasteride and 55% with oral finasteride. Certainly less with topical finasteride. It's interesting that there is some decrease with topical finasteride. And so this may have relevance as we think about certain clinical scenarios where we may not want any reduction in DHT. But the data here suggests that there was no differences compared to placebo in these key side effects like sexual dysfunction. So really important study, which shows us that topical finasteride in these 323 patients has pretty good safety and pretty good outcomes. So we'll be hearing a lot more about topical finasteride in the years ahead. So we leave androgenetic alopecia and we turn now to studies of alopecia areata. Two studies we'll talk about with alopecia areata. Alopecia areata, if you're not familiar, is an autoimmune disease. 2% of the world has alopecia areata. And so it's a very common condition. There's a variety of different types. There's mild alopecia, moderate, and severe. If you lose all of the hair on the scalp, it's called alopecia totalis. If you lose all of the body hair, eyebrows, eyelashes, that's called alopecia universalis. I'd like to highlight a really important study looking at the cardiovascular risk associated with having alopecia areata. And I think this is really the start of some really, really important paradigm shifts in how we start thinking about alopecia areata. We currently have viewed alopecia areata as an autoimmune scalp disease. And where we are now emerging to appreciate is that alopecia areata is a systemic disease. It's a full body disease. And this is very important. So for those of you who joined me last year in the top 20 of 2020, we reviewed this study. This was a study by Dr. Connick, Dr. Birdfeld's group at the Cleveland Clinic, looking at the risk of heart disease in patients with alopecia areata. And this study showed that patients with alopecia areata have an increased risk of metabolic syndrome, 5-fold increased risk, a higher incidence of diabetes, hypertension, high cholesterol, heart disease, stroke. And so this was a very interesting study and in some ways a surprising study. And shortly after this particular study was published, another study came out by Lee and colleagues that said there's no increased risk of heart disease in patients with alopecia areata. And soon thereafter, there was another study, actually came before, suggesting that no, indeed there is an increased risk of heart disease in patients with alopecia areata, but that risk doesn't show up until somewhat later, after 8 years. So there's been a little bit of uncertainty in the medical literature and the published data in terms of what is the relationship between alopecia areata and heart disease. This particular study by Dr. Glickman and colleagues from Mount Sinai School of Medicine in New York is a very important study, which really looked at the blood biomarkers of patients with moderate to severe alopecia areata. Can we draw the blood from patients with alopecia areata, study the proteins in the blood, and get a sense of the total inflammatory milieu of that patient? And so let me walk you through this study. It certainly is a very important one for all of us to be aware of. We know in alopecia areata that there's inflammation in the scalp. That inflammation in the scalp and the skin is what causes hair loss. That's very well understood. But is there evidence of inflammation in the blood? Can we draw blood, analyze the proteins, and does this suggest to us that there's inflammation in the blood? Well, this study suggests to us that indeed there is that type of inflammation. So these studies were good studies because they evaluated a very large number of proteins. 350 inflammatory and cardiovascular proteins were evaluated in this study. Prior studies looking at proteins in the blood that are inflammatory looked at 12 proteins, 15 proteins. This is 350 proteins. The authors compared proteins in alopecia areata in healthy unaffected patients. So how do the proteins compare in alopecia areata compared to healthy unaffected patients? And then how do they compare in skin diseases that we know are inflammatory, like atopic dermatitis? And so they took patients with atopic dermatitis that had significant inflammation and enrolled them in this study, as well as patients with significant psoriasis, PASI scores greater than 10. And so how do the inflammatory proteins and cardiovascular risk proteins differ in these four groups? Well, what the authors showed is that there were 74 proteins that differed significantly between alopecia areata and healthy controls. And these were 74 proteins that are recognized to be involved in inflammation and proteins that are involved to be in cardiovascular risk. And patients with alopecia totalis and universalis had the highest amount of inflammation, or what the authors called inflammatory tone. They had the greatest magnitude of these inflammatory proteins and these cardiovascular proteins. These proteins that suggest to us that there's inflammation in the body, that suggests to us that these patients may have an increased risk for cardiovascular disease, strokes, heart attacks. And so this was really one of the first studies that pinpoints this significant degree of inflammatory tone in the blood of patients with alopecia areata. And in fact, when you take the blood from patients with alopecia areata, you can analyze these 350 proteins. And when you look at 86 of them, you can predict just by looking at the blood whether this patient is likely to have alopecia patchiform, totalis, universalis. So the proteins in the blood, by a simple blood test, could actually be used to predict the severity of a person's alopecia areata. Of course, these tools aren't available to us now. This is a research study, but it really highlights that there is this increased inflammation systemically in patients with alopecia areata. And there is this increased amount of these cardiovascular proteins that we know when these are elevated in the blood, that patients that have elevations like this do have a higher risk of heart attacks. They do have a higher risk of heart disease. And so this is really important information. And it really highlights that alopecia areata is a systemic inflammatory disease. We have for so many years viewed alopecia areata as a hair loss only issue. But really what is happening in the field of hair loss medicine is that we're becoming to recognize alopecia areata as a systemic disease. And I think this is really, really important because this will certainly allow us to treat alopecia areata better, but it'll allow us to take better care of patients. If patients with alopecia areata who have totalis and universalis do have increased risks of any of these medical conditions like heart disease, further studies will highlight that as well, but we'll be able to develop better treatment strategies. And perhaps the treatments that help alopecia areata wonderfully are the same treatments that reduce the risk of cardiovascular disease. Of course, that will need to be shown in future studies, but this is a very important study because it really puts alopecia areata on the map as a systemic inflammatory disease. And we need to be thinking that way as we move forward when we treat patients with advanced types of alopecia areata. And so really very, very, very nice study. I'll move on now to a study of late onset alopecia areata. What do we mean by late onset alopecia areata? Well, it refers to alopecia areata developing after the age of 50. Many of you are aware that most people develop, about half of people develop alopecia areata before the age of 20. And about 85% of people develop alopecia areata before the age of 40. So it's really not common that someone comes into the clinic at age 78 with their first episode of alopecia areata. That's pretty rare. This study looked specifically at late onset alopecia areata. And the reason I like this study is it's one of the largest studies in late onset alopecia areata. And so it's a study by Kim and colleagues from Korea, published in the November issue of the Journal of the American Academy of Dermatology. Now, most studies of late onset alopecia areata have been small, 20 or 30 patients, that's it. But those studies have suggested that most people who get late onset alopecia areata are more likely to be female. It's usually not as severe. It usually grows back quite well in many cases with treatment and has a pretty good prognosis. That's been kind of the view of late onset alopecia areata. This particular study looked at 590 patients. They looked through their total database of 4,909 patients with alopecia areata, but they found 590 that had their very first episode of alopecia areata at age 50 or older. And that comprised about 12% of their database. And so this is a helpful number. It suggests to us that almost 1 in 10 patients are going to experience their first episode of alopecia areata after the age of 50. And so maybe a little higher than we've ever appreciated, at least based on this study. 294 patients had follow-up for more than 6 months, and these were patients that were studied. The average age was 56 years. About 80% of patients had less than 50% of the scalp involved with alopecia areata, and 90% had either complete hair growth back after treatment or partial hair growth back. One of the things I really appreciated about this study is it gave us some information about alopecia totalis and universalis. When we see patients that are 60 years of age who have their first episode of alopecia, if it's totalis or universalis, is it going to be easy to treat? Is it going to be more refractory to treatment? We know that often when patients lose all of the scalp hair or all of the scalp and body hair, it can be a little more challenging to treat. And this study in late onset alopecia suggested that it is difficult to treat. Of 19 patients with alopecia totalis, everyone had some improvement. So that's important to note first. But about half of the patients had poor responses. 2 of the 19 had a complete regrowth, 7 had partial, but half had very poor responses. Of the 8 patients with alopecia universalis, which means total body hair loss, 3 had partial remission, 3 had poor responses, and 2 had no responses at all. But none of those 8 patients had total regrowth. And so a helpful study reminding us that late onset alopecia areata certainly does occur, and maybe up to 10 to 12% of patients that do get their first episode after 50. It generally does have reasonably good prognosis. 90% get partial or complete regrowth of hair, but it reminds us that alopecia totalis and universalis are challenging to treat also in this group. And so even though other forms of alopecia seem to be very responsive to treatment, totalis and universalis are a little more refractory. I'd like to move now to a really important study looking at minoxidil. We're not going to talk about the use of minoxidil in humans. We're going to talk about an absolutely fascinating study of minoxidil in cats and dogs, looking at the toxicity of minoxidil. And I think this study is so important for us to be aware of. If you're a pet owner, it's extremely important. If you are a physician, it's extremely important. If you have family or friends who use minoxidil and are pet owners, this study is really important. So we do know that minoxidil, which goes by many names, Rogaine, Regaine, these are commercial products. It is known to be toxic to animals. It's always thought that minoxidil is more toxic to cats than dogs. And there's been a lot of small studies in the veterinary literature over the last few years of pet owners applying minoxidil to cats where they've lost hair and the cat's becoming quite sick. And so it's been very well known that minoxidil is potentially toxic to animals. It has been thought that cats lack this pathway, this glucuronidation pathway, so they can't metabolize minoxidil very well. And so it builds up, and that's why it's toxic. And it has been thought that maybe dogs are less susceptible. This study that was published in the Journal of the American Animal Hosp Association changes our views on minoxidil forever. and I really appreciate this opportunity to review it with you. This was a study of 78 dogs and 133 cats that had some kind of topical minoxidil exposure. Pet owners had phoned into the Animal Society for the Prevention of Cruelty to Animals, this poison control center. Pets were brought into vets. And so this database started forming of pets that had exposure to minoxidil. There was 133 cats that were in this database. 53% of them were exposed to minoxidil, but had no sort of toxicosis. And by toxicosis, we mean lethargy, low blood pressure, problems breathing, nausea and vomiting. These sorts of issues comprise toxicosis. 12% had suspected toxicosis and 33% had proven toxicosis. There were 78 dogs in this database. 68% had no toxicosis, 13% had suspected toxicosis, and about 20% had proven toxicosis. So the rate was less in dogs. So there was 87 animals in this study that had toxicosis, and 94 needed hospitalization. And that was 62 cats and 25 dogs. And these pets got sick within hours or days after being exposed to minoxidil. And how do pets get exposed? We've long thought that cats get exposed because owners put the minoxidil on the pet. We know from this study that that's probably not accurate. Cats tended to get exposed in this study from unintentional delivery. The pet licked the owner's skin. The pet licked a pillowcase. The pet was splashed by small amounts of minoxidil. And even if the minoxidil was washed off immediately, some of these cats still got sick. Dogs got exposed to minoxidil in a different way. They weren't licking it off as likely. They weren't licking pillowcases, but they were rummaging through trash. They were finding it. They were finding tissues. They were finding tissues with just one drop of minoxidil on it, and they were getting sick. So even with very low exposures, even with one lick, even with one tissue with a small amount of minoxidil that was in some trash can, pets were getting sick. And so this is a really, really important study which reminds us of the potential toxicity of minoxidil to animals. And if a pet does become sick, they're feeling more tired, they're lethargic, they're vomiting, it's very likely that they go on to develop a more significant illness. So we have to take this seriously. 12%, almost 13% of cats died in this database. There were no deaths in dogs. But this was really one of the first studies in a large study that documents that minoxidil has this potential toxicity to our animals. And I think it's really important because the thought has been that, you know, minoxidil, maybe it's safe if it dries. And patients ask often, do we put the minoxidil on and once it dries, the cat can sleep at the top of the bed? This study suggests no, they can't, that minoxidil is potentially toxic and we cannot allow a cat to come into exposure with even dried minoxidil. And so cats are not getting exposed because an owner puts it on areas of hair loss on the cat, trying to help the hair grow back. No, cats get exposed from their licking of faces, scalps, hands, bottles. Dogs get exposed from rummaging through trash cans. So the point I'd like to make is that we really need to be aware of this, that minoxidil is toxic. We need to encourage our patients to store minoxidil bottles properly. Pets really can't sleep with owners unless the scalp is completely covered. We have to be attentive to pillows. And if we leave the bed and the pillow is exposed to minoxidil and the cat remains there, that is really not good. So a really, really important study about the potential toxicity of minoxidil. And I think that's important for us all to be aware of throughout the world with the large number of pets that are part of our lives. I turn now to scarring alopecia. There's many scarring alopecias, lichen planopilaris, central centrifugal cicatricial alopecia, frontal fibrosing alopecia. Scarring alopecias are hair conditions that often have inflammation associated with them. They're really important to identify because the hair doesn't often grow back very well. Sometimes it doesn't grow back at all. We're going to start with a study of central centrifugal cicatricial alopecia. CCCA is how we say it for short. CCCA is a common scarring alopecia in Black women. It's very, very much underdiagnosed. Probably 15% of Black women have CCCA. It occurs in women 30 to 50 years of age, often affects the central scalp. There have been prior studies published in the medical literature, and you can see the dates here, that have suggested that women with CCCA may have certain medical conditions. Uterine fibroids are one such condition that is thought to be increased 5 or 6-fold in this study in women with CCCA compared to women who don't have CCCA. And there's also been a suggestion that women with CCCA have an increased risk of diabetes. There's also been this view that maybe women with CCCA have a pro-fibrotic tendency. So maybe inherent to the condition, they form scarring in the scalp and maybe scarring in other organs like the uterus, maybe other organs as well. Maybe there's this tendency to form scarring, maybe even in the kidney. And so my colleagues, Dr. Samrio and Dr. Mirmarani in California performed a very, very nice study looking at some of these associations in women with CCCA, published in August in the Dermatology Online Journal. And these authors set out to determine if women with CCCA have a greater risk of these so-called fibroproliferative disorders, these conditions whereby scarring occurs in various organs. And if you're not familiar with fibroproliferative disorders, these are conditions whereby there's increased scarring in organs like the lung with interstitial lung disease, in blood vessels with atherosclerosis, in the liver with steatohepatitis, in the kidney with renal disease, and in the uterus with fibroids, medically known as uterine leiomyomas. So Dr. Samrio and Dr. Mirmarani performed a study looking at 427 women with CCCA, and in a 3-to-1 matched control study, looked at 1,281 women without CCCA and asked the simple question, do women with CCCA have a greater chance of having fibroids or any of these other fibroproliferative disorders? And in their study, they did not find an association between CCCA and interstitial lung disease, blood vessel disease, liver disease, kidney disease, or fibroids. So in contrast to the DINA study of 2018, this study didn't show an increased risk of fibroids. Women with CCCA still have fibroids, but it doesn't seem to be increased compared to women without CCCA. So in this study, 28% of women with CCCA had fibroids, 24% of women without CCCA had fibroids, and this was not statistically significant. So these differences were not statistically significant. So what associations are there with CCCA? Well, it's a really important study because it allows us to address this question further. Is there really this risk of fibroids in women with CCCA or not? There's been thought to be this risk of diabetes in women with CCCA. Dr. Samrio and Mirmarani looked at this database to look at whether there was an increased risk of diabetes. They didn't find it. 18.5% of women with CCCA had diabetes, and this was not any different, statistically non-significant from women without CCCA, 20.9%. So there didn't seem to be an increased risk of diabetes over controls in women with CCCA. So a helpful study, a really important study, a well-controlled study, which addressed these questions. And so it really fuels more research, but I think it's really a fundamental part of our scarring alopecia literature, which questions these associations. So what are the associations? Fibroids needs to be studied, diabetes needs to be studied, it's not clear. But a new study looked at the potential risk of breast cancer in women with CCCA. This was a study published in March of the journal American Academy of Dermatology by Brown-Corsaw. And why did these authors set out to look at the potential relationship between breast cancer and colon cancer? Well, it was discovered very recently that women with CCCA have reduced levels of PADI3, and about a quarter of women have a reduced expression of this protein. And this particular protein is thought to have a role in breast cancer and colon cancer. And so the question then becomes, because this protein is reduced in some patients with CCCA, could it be that that confers an increased risk for breast and colon cancer? So Brown-Corsaw and colleagues evaluated CCCA patients and breast cancer patients and colon cancer patients in this large database in Philadelphia, Pennsylvania. This was the University of Pennsylvania Health System, where they looked at data from 2016 to 2020, looking at CCCA patients, breast cancer patients, colon cancer patients. They found 742 patients that had been coded as having CCCA in that database. 4.7% of those patients had breast cancer. And compared to controls, only 1.8% of controls had breast cancer. So the suggestion here is that maybe there's an increased risk of breast cancer in CCCA patients with an odds ratio of 2.61. When they looked in that database at specifically patients that had a biopsy attached to their chart, biopsy proven CCCA, 4.4% of those patients had breast cancer, again, compared to 1.8% of controls, with an odds ratio of about 2.5. There was no increased risk of colon cancer in women with CCCA. And so this is an interesting study because it draws into question the possibility that women with CCCA could potentially have an increased risk of breast cancer by up to twofold. So more studies are needed. We need to study this with different databases, with different ways of looking at this to see if we can replicate or refute these findings. But I think it's a very valuable study, which sets the stage for really more very important studies in this area. And clearly, if there is a risk, we need to make patients aware and perhaps think carefully about what type of screening we do in women with CCCA, but those are studies that have yet to be done. I'd like to turn now to an interesting study in frontal fibrosing alopecia. We're working our way now through some wonderful studies in the scarring alopecia literature. Frontal fibrosing alopecia is a condition that is becoming an epidemic. More and more women and men around the world are being diagnosed with FFA. And for reasons we really don't fully understand, this condition didn't seem to be reported in the medical literature before 1994, when it was first reported by Dr. Cossard. But FFA is becoming more and more common. And very rarely a day goes by that I don't see a patient with FFA. It's a condition that causes scarring along the frontal hairline, but also causes hair loss along the back, causes eyebrow and eyelash loss, body hair loss, underarm hair loss, pubic hair loss. It is a scarring alopecia. It's thought to be autoimmune, and patients with FFA have an increased risk of several autoimmune diseases: hypothyroidism, lupus, psoriasis, lichen planus. These risks tend to be small. Hypothyroidism is the most common association with FFA. We don't typically see patients with FFA with lupus, but we know studies suggest that it is increased. Lichen planus might be increased as well. But there's a condition called lichen sclerosus that I'd like to review with you today. It's a condition that affects the genitals, affects vulvar skin and penile skin in men. And it's a condition that is troublesome for patients, embarrassing for patients, and often not discussed with physicians, especially hair doctors, because the thought is that this couldn't have any relevance. And so lichen sclerosis affects both women and men. It's more common in women, where it causes these whitish patches in the vulva. That's itchy, it burns, and it is perhaps under-recognized in patients with FFA, and that's why I draw your attention to it today. This is a study by Grassi and colleagues from February in the Journal of Cosmetic Dermatology, which evaluated 119 patients with FFA seen over this period 2003 to 2019. There was 8 men with FFA, 111 women. Lichen sclerosis, these whitish patches, were found in 10% of patients, and 4.38% of patients had both lichen sclerosis and then skin lichen planus. And so compared to the general population, where this condition occurs in about 3% of patients, this study is suggesting to us that maybe lichen sclerosis is increased. And I draw your attention to this study, especially the physicians on this webinar who see patients with FFA, that I think it's really, really important that we ask about some of these symptoms, because it probably is underdiagnosed and patients may not feel that it's related in any way, that the autoimmune predisposition to FFA may increase the predisposition to lichen sclerosis. So is it really rare, or is it just that we don't ask? We don't know. There's been several studies of lichen sclerosis in FFA in the literature. Feldman and colleagues reported 2 patients back in 1996. McDonald and colleagues in 2012 found 1 patient out of 60 with lichen sclerosis. Dr. Van O'Galvan's study in 2014, which had 355 patients, reported 1. And Sarace and colleagues in 2019 had 1 out of 65. And this study, Grassi, had 15 out of 119, so 10 or 11%. And so I think this is a really important study. It really reminds us that we may be missing some of the diagnoses of lichen sclerosis in both men and women. And I think it's really important that we ask these questions to patients and feel comfortable asking, because it can really dramatically change people's lives if we can get patients connected with physicians that can properly diagnose this, whether it needs a biopsy or not, get patients connected on treatments which can be dramatically helpful. We can change people's quality of life dramatically. So next we move from frontal fibrosing alopecia to lichen planopilaris, or LPP. LPP is a condition that I see very commonly, and dermatologists that see hair loss patients see scarring alopecias like LPP very commonly. It's a condition that causes hair loss in the frontal, mid, crown. It can cause hair loss all over. It's itchy, it burns, it's red, it hurts, it's tender to touch, and it causes permanent hair loss unless we catch it early. This next study looks at the relationship between lichen planopilaris and heart disease. Very, very interesting study. Prior to this study that I'm about to tell you about, we've kind of wondered whether lichen planopilaris has a decreased risk of heart disease. Some studies have suggested that there's a decreased chance of having high blood pressure, a decreased risk of having heart disease. Some studies suggest a decreased risk of high cholesterol. Some studies suggested no change, but maybe a decreased risk of stroke, heart failure, diabetes. That's kind of been the tone in some of these small studies, which have had 100 patients, 200 patients. This new study by Connick and colleagues, again, from the Cleveland Clinic, Dr. Bergfeld's group, really throws all that into question again as to whether the studies we've had before just haven't been appropriately powered to answer this question. Do patients with lichen planopilaris have an increased risk of heart disease or not? And so this was a study using a very, very large database. And now that we're using electronic records and patient data is punched into these computer systems, we can have control groups with 63,442,000 control patients. So that's the power of electronic databases, is really to get these large studies, which allow us to ask some pretty good questions. So those 63 million patients were the controls, and this was compared to 3,170 LPP or lichen planopilaris only patients. Frontal fibrosing alopecia patients were not included in this study. This study by Connick and colleagues found an increased risk of high cholesterol, 6.5-fold odds ratio, higher risk of blood pressure problems, obesity, diabetes, and a 10-fold risk of metabolic syndrome. They showed a 1.7-fold increased risk of cardiovascular disease or coronary artery disease, atrial fibrillation, and heart attacks. Small magnitude, but nevertheless statistically significant. So this is really an important study because we are entering this era now where we're beginning to think about all of these conditions that we see in the clinic as not only being hair loss conditions, but being conditions that are associated with certain systemic issues that we need to pay attention to. And this study suggests that LPP is associated with metabolic syndrome, which can increase the risk of heart disease. The data that's emerging is suggesting that alopecia areata is associated with this similar metabolic syndrome. And androgenetic alopecia has long been known to be associated with metabolic syndrome. The pathways leading to this may be different, but this is really important data, which will really fuel some additional research to understand this better and to understand these important systemic associations. But I think it's really, really important. For now, it certainly suggests to us that with this data, we probably should be thinking about testing blood pressure, testing cholesterol, screening for diabetes, and looking at the BMI or the weight of patients, and looking for ways to reduce risks in patients that are obese or overweight. And so really, really important studies. And I thank the authors for this body of data. We move on to a study of oral minoxidil in lichen planopilaris. Oral minoxidil, as I mentioned, is very popular nowadays. We've talked about 5 milligrams once a day in androgenetic alopecia. Here we'll talk about oral minoxidil in lichen planopilaris. This was a study by Dr. Sergio Vano Galvan and colleagues from Spain, along with colleagues in Australia, looking at the use of oral minoxidil in lichen planopilaris. And so Dr. Vano set out to evaluate how well oral minoxidil works in patients with classic lichen planopilaris. There's 51 patients in the study. 71% were women, 29% were men. Men were on a higher dose than women, and that's very typical of oral minoxidil. Most men tolerate 2.5, 5 milligrams. Women generally tolerate 0.25, 0.625, even up to 1.25. So the doses are lower in women. So the mean dose in men was 2.7 milligrams. The median dose in women was 0.75 milligrams. The mean duration of therapy was 21 months. Some patients were followed for 6 months, but some patients were followed up to 87 months. Hair thickness improved in 39% of patients. It stayed the same in 53 and it worsened in 8. And so pretty impressive number, but 40% of our patients with LPP potentially can have benefits with oral minoxidil. Patients with diffuse LPP, so hair loss all over, front, back, sides, responded better than patchy lichen planopilaris. And males that were on a higher dose responded better than males that were on a lower dose. And so if a male patient tolerates half a pill, they may benefit by going up to a full pill, which is 2.5 milligrams in North America. If they tolerate 2.5 milligrams, consideration can be given to go up to 5 milligrams. That's in males. Here's a study, here's a photograph from Sergio's paper showing very nicely a patient on 1 milligram of oral minoxidil. They were on hydroxychloroquine and topical steroids, and this is the nice improvement they had with the use of oral minoxidil. Pretty impressive improvement in thickness. What are the side effects? Well, hair growth, excessive hair growth occurred in 14 patients. Hypotension, low blood pressure in 3, elevated heart rate in 2, and weight gain in 1. So this is one of the first studies to document the benefits of oral minoxidil in classic LPP, so a study dedicated only to LPP. We don't entirely know the mechanism. This study didn't set out to really address the mechanism. Certainly we know that hair thickness improves and patients feel my hair is better. I'm glad we did that. We don't know if it's really addressing the androgenetic hair loss and really helping the androgenetic hair loss get better, or whether there are some fundamental aspects of the scarring alopecia which are improved as well. If minoxidil sends a growth promoting signal to these hairs that are trying to battle the scarring alopecia, it's possible that they could be revived as well. And so the mechanisms are still a little bit unclear, but nevertheless, this study suggests that oral minoxidil is an option. We'll go on now, study number 17, to talk about a study in breast implant illness, a subject that really doesn't get a lot of attention, but a concept that's really important for all of us to know who see patients with hair loss. And I'll review this now. In 2020, about 193 breast augmentation procedures were done. Another 80,000 procedures were done for reconstruction in patients that had cancer and other reasons that needed reconstruction. The highest rates were back in around 2007 in the US, where around 400,000 patients underwent breast augmentation. There are patients who've had breast implants who have symptoms, and they attribute these symptoms that they are feeling to their breast implant surgery. And this is called breast implant illness. And so there are a large number of symptoms that are shown here that patients attribute to the fact that they underwent breast implant surgery, ranging from fatigue to depression to brain fog to joint pain to bowel and bladder issues to thyroid issues to decreased libido. Hair loss is one of these issues. And so it's not an uncommon scenario where patients come into clinic with hair loss and ask, do you think that my hair loss is caused by my breast implants? And if you do you think I should see my plastic surgeon to have them removed? This is a really, really important question, which can be challenging in some cases to answer fully. But the study I'm about to review with you gives us some very valuable tools to go about helping this patient that comes in with these questions. And with 1.7 million people worldwide each year that have breast augmentation, these are important questions that we need to have some answers to. So first, let me review some of the history of breast implants. Some of the first breast implants in North America were silicone gel implants in 1962. And then in 1992, the FDA removed silicone implants from the market. They were still allowed to be used in some patients who had necessity for reconstruction, but they were no longer allowed to be used. And the reason is because some of the data on safety was not being followed. The FDA felt that companies that were making these materials weren't really studying their patients and the safety and side effects. In 1999, the Institute of Medicine published a report that suggested that there doesn't seem to be any increased risk of cardiovascular disease, autoimmune disease, neurological disease in women that are receiving silicone implants. And so in 2006, the FDA approved 2 silicone implants, one by Mentor and one by Allergan. And the FDA was very strict in saying that we will bring these to market. Saline implants had been in the market prior to this as well. They didn't have the same strict regulation. But the FDA said that if a company is going to make these products, they need to study the safety moving forward. And so the period 2006 to 2021 has been a period of studying the safety. Are there any side effects? Are there neurological issues, cardiovascular disease? In 2011, the FDA shared data with the public suggesting that there's a very small risk in textured implants, a very specific type of implant, textured implants, either saline or silicone, that increases the risk of a cancer called anaplastic large cell lymphoma. The risk is low, but the FDA said it's a true risk. Fortunately, it doesn't occur very often, but it is a risk. The studies that have come out since then have suggested that doesn't seem to be a clear increased risk of cardiovascular disease, neurological disease, heart disease, and other issues. Some studies have suggested yes, most studies have suggested no. It still is an ongoing area of study. So now we come back to breast implant illness. What are we going to advise patients that ask us these challenging questions? Do you think my hair loss is caused by my implants, and should I have the implants removed? Well, this study from July of 2021 is a very valuable study which sets us up to be able to offer some assistance to those patients. This was a study which involved a 20-question survey, which was administered to a Facebook group known as the Utah Breast Implant Illness Group, to characterize the symptoms that are attributed by the individuals in this group to breast implants. 192 patients completed the survey. That was a very small response rate, about 15% of the total number that could complete the survey, but nevertheless, 192 patients completed the survey. In 97% of respondents, their health issues began about 2 or more years after the breast implants. 60% of patients learned about this phenomenon of breast implant illness from family or friends. 56% learned from social media, 50% learned from the internet. The most common symptoms associated with breast implant illness was brain fog, fatigue, joint pain, and fourth was hair loss. And that's why all hair specialists worldwide absolutely need to have some understanding of what breast implant illness is about, what patients are referring to when they talk about this, because 74% of patients may report hair loss. Now, 70 patients in this study had explantation or removal of the breast implants. And in 23% of patients, there was complete improvement of symptoms. In 74% of patients, there was partial improvement. And in 3% of patients, there was no improvement at all. Let's look at hair loss. 59% of patients that had the implants removed had an improvement in their hair after removing the breast implants. That was based on a survey, so that's based on their opinion. Women that had a complete resolution of symptoms were more likely to have a large number of symptoms before undergoing surgery, an average of 20 or more. And women that had a partial improvement in symptoms had an average of 10 symptoms before removing the breast implants. This is an important study because it really fuels additional studies in this important area. This study has limitations. All survey-based studies do. All studies that draw patients from the internet have their limitations, absolutely. this study has some very helpful points for physicians who see patients with hair loss. So how do we address these questions? Do you think my hair loss is caused by my implants, and should I have them removed? Well, a patient who comes into clinic and has hair loss as the only symptom and is wondering, do you think my hair loss is attributed to breast implants? It's challenging to say for sure, but the answer is most likely not. Even patients that have a limited number of symptoms, again, it's challenging to know definitively. The data, the long-term data isn't there. But with a small number of symptoms, it's hard to say, but maybe not. But if patients have a very, very large number of symptoms, and when they're screened for all of these various parameters that constitute breast implant illness, if there's a large number of symptoms, 20, 25, that patients agree to, this particular study would suggest to us that removal of the breast implants has a high likelihood of either giving partial improvement or complete improvement in symptoms. It's by no means a guarantee, but this is a very helpful study which tells us that up to a quarter of patients with breast implant illness that undergo surgery feel that they have a complete improvement in all symptoms. So the reasons are not clear. The etiology of breast implant illness is not clear, but nevertheless, an important study that suggests when a large number of symptoms are present, some quality of life can improve by removal of the implants. So we move on now to talking about chemotherapy-induced alopecia. Hair loss after chemotherapy is very common. About 60 to 70% of patients who undergo chemotherapy lose their hair. And there's two types of hair loss after chemotherapy that are common. One is temporary chemotherapy-induced alopecia, and the other is persistent chemotherapy-induced alopecia. In temporary chemotherapy-induced alopecia, which is the one that most of us are most familiar with, patients lose hair starting a few weeks after receiving chemotherapy, and then it starts growing back about 3 or 4 months after the chemotherapy is stopped. Persistent chemotherapy-induced alopecia is something different. And this is a type of hair loss where patients undergo chemotherapy and they lose hair, but they don't regrow all of their hair back. They're waiting for it to improve, but it does not all grow back. And that is persistent chemotherapy-induced alopecia. It also goes by the name permanent chemotherapy-induced alopecia, but the term persistent is preferred. Persistent chemotherapy-induced alopecia is a devastating condition whereby not only are patients going through the emotional struggles of dealing with cancer, but also the hair does not come back. And it's a condition that is becoming very much an important subject among patients undergoing chemotherapy for breast cancer. One of the common treatments for breast cancer is medications called taxanes. And many of these, like docetaxel and paclitaxel, can cause persistent hair loss. In other words, women who receive these medications to treat breast cancer lose hair initially, but it doesn't all come back in every single patient. Fortunately, in most patients, it still does come back, but about 20% of patients on docetaxel may have persistent hair loss, and a smaller percent on paclitaxel. So this study in November set out to look at some of the characteristics of persistent chemotherapy-induced alopecia, a really important subject. So this was a retrospective review of patients with persistent chemotherapy-induced alopecia after chemotherapy for breast cancer. The authors looked at the clinical characteristics of patients, what the hair looked like by trichoscopy or up-close magnification, what the biopsies looked like, and how these patients were treated How can we get this hair to grow back better? There was 100 patients in the study. The mean age was 54, and the chemotherapy was mostly these taxanes, docetaxel in 84, paclitaxel in 8. That's one of the more common types of chemotherapy regimens, a first-line treatment protocol for many women with breast cancer. So there are many patterns of hair loss in permanent or persistent chemotherapy-induced alopecia. One was a diffuse type of hair loss all over. One was a pattern that looked just like female pattern hair loss, and that was the more common. There was a male pattern hair loss and a scarring alopecia, including 2 patients that had a frontal fibrosing alopecia-like presentation, as well as some patients that had lichen planopilaris. This study also documented eyebrow and eyelash changes. It hasn't really been clear how commonly permanent or persistent chemotherapy-induced alopecia affects eyebrows and eyelashes, but eyebrows were reduced in 50% and eyelashes were reduced in 32%. So what did the hair look like by trichoscopy when you use these fancy magnifying devices? It looked just like androgenetic hair loss in 88% of patients. And in 9% of patients, it looked like a scarring alopecia. This is really, really important because women who come into clinic 6, 9, 12 months after chemotherapy and say, I have hair loss, many of them will be misdiagnosed as androgenetic hair loss because it looks just like androgenetic hair loss. The key question is, do you have pictures of your hair before you underwent chemotherapy? And if the hair failed to come back fully after chemotherapy, 6 months or more after, that is the diagnosis of permanent or persistent chemotherapy-induced alopecia, or PCIA. So it can look just like androgenetic hair loss. When the scalps were biopsied in 14 of the 18 patients that had biopsies, it looked just like androgenetic alopecia. So not only does it clinically look like androgenetic alopecia, when you biopsy, it looked like androgenetic alopecia. In 2 patients, there was a scarring alopecia with loss of sebaceous glands. That's one of the hallmarks of scarring alopecia. And in 2 patients, there was features of both. How were these patients treated? One of the things I really liked about this paper by Rule and colleagues is they looked at treatment. And benefits were seen in these subset of 49 patients with topical minoxidil, oral minoxidil, as well as oral minoxidil with these various anti-androgens. And so some improvement can occur when we treat PCIA. So the conclusion here is not to mistake PCIA for typical androgenetic hair loss. It has features of androgenetic hair loss. Sometimes it looks perfectly like androgenetic hair loss. There may be features of scarring alopecia, and so don't let that fool you as well. Biopsies can often be helpful in PCIA. And treatment may help partially reverse. So there is hope for many of these patients that hair can improve with topical minoxidil, oral minoxidil, as well as other treatments. So let's talk about chemotherapy-induced alopecia again, but talking about scalp cooling. Scalp cooling is a treatment that has been around in Europe for many, many years, maybe 20 years, but has recently come to the United States in 2015 when DigniCap was approved, and 2017 when Paxman was approved. And here's the Paxman cold caps. These are devices which are applied to the scalp of patients undergoing chemotherapy to cool the scalp. And by cooling the scalp, these devices reduce the amount of blood flow to the scalp and reduce the amount of blood flow of chemotherapeutics to the scalp of patients with solid tumors like breast cancer and other solid tumors, and reduce the chances of hair loss. And both the DigniCap and the Paxman devices showed that a very significant proportion of patients that were using these scalp cooling devices were able to limit and dramatically reduce the amount of hair loss undergoing chemotherapy, such that many, 50 to 60% of women did not need to have a wig to camouflage hair loss or a scarf to camouflage hair loss in the weeks and months after chemotherapy. And so a really, really important treatment advance in the hair loss that accompanies chemotherapy-induced alopecia. But a question that has remained is, are there differences in how well scalp cooling works in different racial backgrounds? Does scalp cooling work just as well in Black women? And that was the focus of this study in April of 2021 in The Oncologist. And I'd like to highlight this study. In this study, Black patients who plan to receive chemotherapy with either anthracycline or non-anthracycline chemotherapy regimens were eligible for the trial, and 15 patients enrolled, but it was closed early. The trial was terminated early because only one patient of those 15 was successful in keeping their hair or preventing hair loss beyond a grade 2 level. So there's different grades that hair loss occurs, but only one of 15 patients was able to successfully keep the hair. And so this was really one of the first studies evaluating scalp cooling in Black women undergoing chemotherapy. Really, really important study. The exact reasons are unclear, but it could relate to some textural differences in the hair. As women undergo scalp cooling, often the hair is wettened. And the application of moisture to afro-textured hair sometimes increases the volume of hair and makes the caps more difficult to fit tightly and properly, which may reduce the effectiveness of these caps. So a long way to go to really understand how best to use these caps in different racial backgrounds, but a really, really important objective for the future, because these scalp cooling devices can work very effectively for many patients and dramatically alter the quality of life. Hair loss after chemotherapy is among the most emotionally challenging things that happen, that patients undergoing chemotherapy rate as being some of the most emotionally difficult parts of the chemotherapy experience. And so having treatment options that stop hair loss are really, really important. And so this is the first of its kind in Black women undergoing treatment. The final study, and then we'll open to questions, is a very nice study looking at the use of photography in the clinic. My camera comes with me everywhere. I take dozens and dozens of pictures, and I encourage the physicians and trainees that work with me to appreciate the value of pictures and taking pictures. Having before and after photos is so valuable, and really it's very difficult to do a clinic without having good before and after pictures. And this study by Dr. Senna's group from Boston really highlights the value of photography for patients. It's challenging for patients to know if they're getting better sometimes. There's tremendous anxiety that is attached to losing hair. Hair means a lot to us as human beings. And when we see ourselves every day, it's really difficult to know if our treatments are working. Some of these treatments take 3, 6, 9 months to show effects. And when we see ourselves every day, it's challenging to figure out if these treatments are working, and that only increases the anxiety. And so hair loss really is extremely emotional for many patients and impacts self-esteem, as associated with anxiety. And as I mentioned, it's hard to know what's helping. And so this study by Pathulos and colleagues, this is Dr. Senna's group from Boston, set out to look
at the value of photography. And this study is very unique because it captures very nicely what photography can do. So this was a study of patients with androgenetic hair loss and scarring alopecia that were coming into clinic. They completed a pre-visit and a post-visit survey, which I'll review with you in a minute. And these surveys that patients filled out before they were about to come into clinic asked them, do you think your hair loss is worse since your last visit? Do you feel anxious about things? And after you've had a chance to view photos in the clinic, do you think these photos helped you? And after seeing these photos in the clinic on your visit, do they motivate you to keep going with treatment? Do the photos provide any benefit? And so patients filled out this pre-visit survey before they came in to see the doctor. Then photographs were taken, and these photographs were presented to the patient. Here's what you look like now. And then patients completed a survey after their visit. What'd you think of the photos? Did the photos help? Did the photos show that things are better? Did the photos reduce your anxiety? So there was 119 surveys that were completed. In 34% of patients that completed the pre-visit surveys, 34% of patients felt they were worse or much worse than they were 6 months ago. So they're coming into the clinic feeling, I'm much worse off. I need to see the doctor. And in 81.5% of patients, there was significant anxiety attached to that visit. This is really one of the first studies of its kind to really document numerically the magnitude of some of this anxiety. Then patients evaluated their photos in the clinic that were taken by the doctor. And then they completed a survey after their visit. 53% of patients rated their alopecia after the visit as being less severe than they originally thought. 81.5% of patients had decreased anxiety. 98% of patients felt the photographs were useful, and 98% felt motivation to keep using the treatment after having the opportunity to review these photographs. And so this is really a unique study, and it really emphasizes just how valuable photographs are in the clinic and how valuable it is to take photographs before and afters, to review them with patients, to help patients understand really how they're doing in their progress. It is very, very difficult for patients sometimes without these photographs to judge how they're doing because of the tremendous anxiety that's attached to losing hair. And so photography helps reduce anxiety, it clarifies if a treatment is helping, and it motivates patients to continue. And I really like this study. I think it's a one-of-a-kind study which captures some of the anxiety that these patients feel and the real value of photography. So I'd like to stop there and open it up to any questions. And I see we have some questions. I really do think that these are 20 very, very nice studies, and I congratulate the authors. They really are studies that set the stage for doing things differently, thinking about things differently. And I think that they really highlight some important associations that we need to be thinking about in patients with these various types of hair loss.